Hello, good morning. My name is Javier Nieto. I'm representing Dr. Eric Haas today. And we, the authors, have nothing to disclose. Single incision laparoscopic colectomy has been proven to be a safe and feasible approach to this day. However, the benefits and limitations have yet to be established. And the learning curve represents the acquisition of competency for the new surgical procedures so that the surgeons can evolve with ease into mastering the skills necessary to perform these new procedures with safety and successfully in all of their patients. To this day, we have not found a learning curve appraisal of the single incision laparoscopic colectomy. And this is why we decided to perform a study over 54 consecutive single incision laparoscopic right hemicolectomies for a 2-year period, all performed by a single surgeon with extensive laparoscopic experience. The learning curve utilized a CUSUM methodology of the operative time across the case sequence. And we did a second CUSUM analysis, which was risk-adjusted, considering 5 risk factors: the age, the ASA, BMI, the number of prior abdominal surgeries, and the presence or not of a bulky tumor on a CT scan for the malignant cases. The operative failure was defined as operative time equal or more than 1.5 standard deviation above the mean, the presence of a conversion in a case, the length of stay of equal or more of 1 standard deviation above the mean, reoperation, readmission, complications, and for the malignant cases, we also included as an operative failure the presence of a positive surgical margins or fewer than 12 resected lymph nodes. What we found was that 27 patients were male, which was the 50% of the cases. The mean age was 63.6 years. The ASA mean was 2.3, the BMI 27.3, about 1 prior abdominal surgery on average for all the cases. We did not have any intraoperative conversions. We had 25 malignant cases. The length of stay was an average 3.9. And our operative time and EVL 123 minutes and 56 cc's. For the high-risk patients' characteristics, 7 patients were above 75 years, 19 patients had an ASA equal or more than 3, 10 patients had a BMI of above 30, 7 patients had more than 3 prior abdominal surgeries, and 4 patients had the presence of a bulky tumor in the malignant cases only. And our operative failure outcome on regards of the operative time, 8 patients were considered a failure, 1 patient was considered a failure for an intraoperative complication, 4 patients had a prolonged length of hospital stay, 9 patients had either a 30-day major complication, a reoperation, or a mortality, one of those. And we had no failure on regards of the conversion to a conventional laparoscopic procedure or open colectomy, and the malignant cases all were oncologic success. The 30-day complications included 4 postoperative ileus, 1 paranostomotic abscess, 1 CVA. There were 2 readmissions, 1 due to a partial small bowel obstruction, 1 due to a diarrhea leading to dehydration. 1 patient died in postoperative day number 3, and there were no reoperations. And this is our learning curve. Here we can see in black on the bottom the learning curve analysis, the CUSUM analysis only of the operative time, and on the top we see the CUSUM analysis for the risk-adjusted failure. What the CUSUM analysis does is, on regards of the operative time, which is what we are analyzing here, is that it goes comparing the the operative time of patient number 4, and it compares it to the average of patient 3, 2, and 1. And it does the same for patient number 5, going backwards to the mean of 4, 3, 2, and 1. And so consecutively, so that it analyzes, it gives us these graphics that looks like a little curve. Now, when the curve is coming down is when we consider that the the surgeon has mastered the skills necessary to perform an equally distributed operative time among all the cases when you compare it towards all your means previously. And we said 30 in the number in operative time, and case 36 for the risk-adjusted failure. Why 30? Why 36? 30 because that's when we have the same, no significant difference between the 30 cases and the following 24 cases. Why 36 on risk-adjusted? Because of the same reason. When you compare both, you see that 30 and 36 have no significant difference. So in conclusion, we see that the learning curve is achieved between 30 to 36 cases. Now, don't let the learning curve scare you. You are already experienced laparoscopic surgeons and you are already driving that Ferrari. Take the wheel, drive that curve with ease, because offering this minimally invasive approach does not place the patient at increased risk, even in the early phases of the learning curve. Thank you very much.
Thank you.
This paper is open for discussion.
Sergio Lorash, Orlando, Florida. I would like to ask you, what did you do with the outliers? That will be feasible if all your sample of cases are equal. But how? What do you do with the cases that are really difficult?
This is the tricky part. We have a selection in the beginning, of course. We do not take patients.
That needs to be stated because you got to be with a selected number of patients.
Correct.
Back microphone.
Hi, Ali Mahmoud. Really enjoyed your talk. Well done. My question is when you were looking at the operative time and the selection criteria, one thing is maybe looking at BMI. Certainly skinnier patients would be easier than more larger patients. And the second question is, I noticed you applied this to right colectomies only. Are you guys at your institution doing it for left colectomies now as well? And sigmoid resections?
Yes, it's done also for left colectomies, for sigmoid resection, for total colectomies. However, for this paper, at the moment that we decided to sit and see all the procedures, we had, at the beginning, we did mainly right hemicolectomies. At the time, at the institution, we have done over 250 cases, including sigmoid resections, total colectomies, ileostomy, and colostomy creation. And I'm sure that we are going to analyze the learning curve of those too.
Great. Thank you. Well presented.
Thank you.
Barry Salke, New York. Enjoyed the paper. Question, do you have any follow-up of these patients yet in terms of incisional hernia formation?
In terms of what, excuse me?
Incisional hernias.
Incisional hernias, that's
I
very...
assume this is you're doing a midline or somewhere around the umbilicus, or are you doing it somewhere else?
Yes, correct. We're doing this through the umbilicus, and yes, we are going to start following up all these patients. We do a follow-up. We do not have a data analyzing how many patients have had an incisional hernia yet, but that's a work that is in the process as of now.
Okay. Well, thank you very much, and thanks everyone for attending this session, and we'll close the session at this time. Thank you.
Thank you.